opening batsman today, and very well organized conference. I mean, the success can be judged by they stopped the registration just 10 days back, saying that house is full. Coming to my presentation, this is a e-poster contributed by me. It's about A-lobar holoprosencephaly, which I got just a couple of weeks back. A 28-year-old primary gravida, she came to my ultrasound clinic for anomaly scan, and on the ultrasound examination I found that there was some lesion in the fetal head. It is a 20 weeks fetus. Typical findings suggestive of A-lobar holoprosencephaly were seen. The cerebral hemisphere was fused. There was no interhemispheric fissure. Falx was absent. Cavum septum pellucidum was absent. Corpus callosum was absent. And the thalami were fused. A single monoventricle, primitive type of single monoventricle is seen in this case. Associated facial abnormality is seen in such cases, and in this case also I found a median cleft lip with a very flat rudimentary type of nose. Eyes were normal. There was no evidence of hypotaylorism. As you can see, the interorbital diameter was 10 millimeter and binocular distance was 32 millimeter. This baby was delivered in my own maternity center by my wife. And you can see the facial defects, median cleft lip and nose is almost absent, and eyes are almost normal. There is no evidence of hypotaylorism. So coming to a little bit of theoretical discussion, holoprosencephaly is perhaps the commonest disorder of fetal CNS, but we don't see much of cases at birth, because most of the cases they vanish in embryonic stage itself. It is a complex spectrum of abnormalities of forebrain due to incomplete separation of the cerebral hemispheres. The prevalence is 1 in 250 in embryonic stage, but most of the embryos they do not survive, and by 11 to 14 weeks itself, the prevalence becomes 1 in 3,000. And at birth, only 1 in 10,000 live births are reported, or stillbirths are reported. Most of the cases, they die intrauterine. Causes are heterogeneous, and most of the cases are sporadic. Chromosomal abnormalities are associated in many of the cases, like trisomy 13 or 18 or triploidy. Single gene disorder are also associated. Almost about 14 genes are associated with this condition. Besides that, diabetes, alcoholism, and certain food toxins, they are also reported to be associated with this condition. Folic acid deficiency is also one of the suggested cause. Classically, we divide holoprosencephaly into 3 types: A-lobar, semi-lobar, and lobar. A-lobar being the most severe, and semi-lobar and lobar being the lesser and lesser severe. There is a 4th type also, syntelencephaly, or middle interhemispheric holoprosencephaly. It is very easy to diagnose A-lobar and semi-lobar in early intrauterine life. Between 11 to 14 weeks, A-lobar and semi-lobar variety can be diagnosed, but lobar variety diagnosis is done little late, around 20 weeks or after 20 weeks of pregnancy. In many cases, a lobar variety is likely to be missed, and these fetuses who are born, they are mostly of lobar type. In the A lobar type, fox and interhemispheric fissure is missing, corpus callosum is absent, there is a single primitive ventricle and thalami are fused. Associated in semi-lobar type, the occipital horns are but frontal horns are missing. And common associated anomalies include facial defects, hydrocephalus. In this case also hydrocephalus was there because the head size was of 22 weeks and rest of the body was 20 weeks. Prognosis is poor in almost all the cases. Thank you.
Excellent, thank you very much. Did you get a chance to do any genetic workup on this particular fetus? Or
no, sir. They did not agree to, the patient did not agree because of financial constraints.
Yes, but tell me, what about just a placental evaluation for genetics or a karyotype for trisomy 13, etc., etc.?
Around, in about 50% of cases, genetic or chromosomal anomalies are expected.
Yes. So you see what is happening is that we now have genetic evaluation for which we don't necessarily have to do a complete autopsy. We have an ultrasound guided features, and we really had excellent information here. And we know that the companies are bringing down their costs so that we can cope with this.
Yes.
And Society of Fetal Medicine has worked so hard to bring the costs down.
Yes.
So every time you encounter such a problem in the future, if the patient agrees for an autopsy, wonderful. If they don't, at least a little piece of the placenta,
yes,
or a little small piece of skin from the upper part of the thigh, yes, and we could do a microarray. But the cost of exome has also come down in the last 2 months, as you know, and we might do it. And if you have any problems with that, if you contact the SFM central office, we have genetic evaluation available even free of cost, yes, from 3 of the companies. Yes. So we'll be able to assist the patient in doing so.
Yes.
Excellent presentation. I love the pictures. Wonderful. To the other judge.
Yeah. Thank you. That was indeed excellent. Thank you so much for your case. As sir was saying, the minimum we can offer them is a DNA storage.
Yes.
So at least if we can do that, if they don't want to do it now, tomorrow if she wants to get pregnant.
Yes.
I think that's one message.
We had asked them, but they refused for it.
Yeah, that's the usual case,
yes,
but
yes,
I think we have to push for that.
Okay.
Thank you.
Thank you.
Sir, very nice images, sir. And I totally agree with sir, but the financial problem is also here. Nobody agrees for so much of expensive tests and all.
Yes.
No, because it is a financial problem and because people don't like to spend on health. I mean, let us face it, today an exome is costing us, if we don't do a trio exome, we just start with a basic exome, it costs us only about 16,000 rupees. And 16,000 rupees is not even the cost of half this row of flowers. And because our sense of proportion is like that. We see these functions every day going on, and they're so elaborate. It's just that we have to convince our patient that, look, you have to have some proportion of what is going on.
So in my area, for 16,000 rupees, they are ready to change the wife itself.
Which is a very good point. But you see here, if you have evidence that you don't need to change the wife for a holoprosencephaly, your next wife might be a carrier of thalassemia, and then so they are gone completely. So we have to sit and explain to them in perspective, in their own language. And I know a lot of people, even in Bihar, for instance, those who speak Bhojpuri will not speak Maithili. But we must learn this and must understand to speak to them in exactly the same language that they understand, yeah, and in exactly the same way that they understand. Some very gentle, some with respect, and some with downright looking down upon them, because it is for the sake of their future.
Yes.
So we'll work on that.
Very nice presentation, sir, and it was really nice start to our conference. Thank you so much for giving your PPT.
Thank you. Thank you very much.
Thank you indeed. And we look forward to many more presentations for you in our next meeting, in the main meeting, of course. Thank you, Madhukar.
Thank you.
Our next speaker is Dr. Mrinalini Singh. The speaker will be given 4 minutes for the presentation and 2 minutes for the question.
Yeah. And may I request all the support staff to kindly keep their voices low or not to talk at all during the presentation.
Good morning, respected teachers, colleagues and dear juniors. I'm here to present a rare case. Mrs. X, 20 years, she came for first antenatal visit at 22-week gestational age. Anomaly scan and quad was advised. Quad showed low risk for aneuploidies. And in ultrasound, it showed a 5 centimeter well-defined oval-shaped anechoic cyst at the insertion of the umbilical cord, which was connected with bladder. Let me take my laser pointer. Here we can see this cyst which is communicating with bladder, and here on color Doppler the cyst was avascular and both umbilical arteries were lying on either side of the cyst. She was advised amniocentesis but she was not willing for the same. This is a small video clip of transverse section in which the cyst is clearly seen anechoic oval shape, and it is seen anterior to anterior abdominal wall and communicating with the bladder. This is again a video clip in long section, and it is again showing the same cyst which is communicating with the bladder. Follow-up scan was done at 28 week. The size of cyst, as we can see here, regressed to 4 centimeter. Amniotic fluid was normal and it is still circular in shape. The pregnancy evolved without complications, and the third trimester scan was done at 33 weeks. Now the size of cyst has regressed further to 1.5 centimeter, but it is no longer anechoic. It was heterogeneous solid with mixed echogenicity, as we can see here. At term, the cyst was too small to find on ultrasound examination. The bladder was always visible from first to third trimester. A live neonate was delivered at 39 weeks by normal delivery, weighing 3 kg. After delivery, here we can see at the umbilical region a ruptured cyst was present. This reddish granulation tissue was a ruptured cyst. Urine was dribbling from this area, and we confirmed patent urachus by inserting a Foley's catheter which ran through this ruptured cyst, and urine came out. The neonate was sent to a pediatric surgeon. This is the OPD prescription and this is the discharge ticket, in which they confirm that this is a case of patent urachus, and the neonate underwent surgical repair of the abdominal wall after 1 month, and no other complications has been reported during postnatal care. This is the picture of the scar tissue after surgery. What is allantoic cyst? It's a rare malformation with a frequency of 3 in 10 lakhs that may be seen antenatally by ultrasound assessment when the connection between the bladder and the umbilicus fail to regress. A patent urachus that presents as a cyst is usually considered not to be associated with chromosomal abnormalities, but if it is not repaired after birth, this leads to complications such as UTI and stone formation. The presentation won't be complete without a word about what is urachus. Urachus is actually a channel between the bladder and the umbilicus where urine initially drains during the first trimester of pregnancy. What happens after 12 weeks? All that is left is a small fibrous cord, and this channel gets sealed off, and what we call it as a median umbilical ligament. Whenever there is difficulty or any problem in sealing off of this channel, there are 4 types of urachal abnormalities. This is the first one, which was my case, in which this complete channel didn't sealed off, leading to patent urachus and dribbling of urine from the bladder into the umbilical site. This is the second type, in which only the proximal part is patent. This presents as an umbilical sinus. This is the third type, in which only the distal part is patent, which presents as bladder diverticulum. And this is the fourth one, when only the middle part is patent, which is called as urachal cyst. And I am very thankful for a patient hearing.
Fantastic. That's extremely wonderfully presented and a very beautiful case, very rare, I must say. Thank you so much. I would just say that, as you said, there are no chromosomal or genetic implications for this condition, is it?
Yes, ma'am.
Yeah.
Excellent presentation, very nice, and I loved your brief but completely comprehensive remarks on how to classify these. That's very, very important because that's what the pediatric surgeon is looking for. I wanted to ask you, did you try, these images were on a transvaginal scan, some of them, or they were all transabdominal?
Sir, all transabdominal scan.
Yes. So this is what the message that the audience must get to go home, that even if you're under pressure and you're getting a good transabdominal view, and you have the pressure of not having to do images for research and for images for PPTs, then you can do a lot of work with the transabdominal view if you use a medium or a high-end machine. Excellent presentation.
Thank you, sir.
Excellent presentation, ma'am. Very rare case, and it was really very nicely presented.
Thank you, ma'am.
Yes, the video clips were outstanding.
Thank you.
Very
ma'am.
good.
Thank you, ma'am.
Our next speaker, Dr. Richa Jha.
A very good morning to the respected judges, my seniors, and my colleagues present in the hall today. Today, my topic of case presentation is evaluation of SFLT1 PLGF ratio for prediction of preeclampsia in the late second and third trimester of pregnancy. So as we all know that preeclampsia continues to be one of the leading causes of maternal and fetal morbidity and mortality, accounting for still about 7% of all the maternal deaths. So it can be divided into early onset and late onset preeclampsia, and each set of them have their own respective set of complications, whereas early onset leads to more amount of adverse fetal outcome in the form of fetal growth restriction, oligohydramnios, and even stillbirth. Late onset preeclampsia is more associated with maternal complications in the form of HELLP syndrome and eclamptic seizures. So the etiopathogenesis revolves around an imbalance between the circulating levels of proangiogenic, that is PLGF, and anti-angiogenic, that is SFLT1 factors, and it results in an increase in the SFLT1 PLGF ratio. This is important because the increase in the ratio is evident about 4 to 5 weeks before the actual onset of clinical symptoms. So this gives us an opportunity to screen or to predict or to carry out tests for such patients who are at high risk of developing preeclampsia and manage them appropriately. My study is different from the other studies because here I get an opportunity to triad such patients who are at a high risk of developing preeclampsia and manage them appropriately by appropriate counseling, more frequent monitoring, and management of these cases at a special high risk centers. So my methodology. It was a prospective monocentric observational study carried out for a duration of 6 months. The sample size was 50 and the place of study was at my hospital, that is Holy Promise Hospital. It was sampling method was a convenient purpose of sampling. And the study population was were the high risk pregnant women attending the OPD between 24 to 30 weeks of gestation, having any of the following high risk criteria, that is increased maternal age, obesity, history of preeclampsia in the previous pregnancy, PAP-A less than 0.4 multiples of median, increased uterine artery PI, twin pregnancy, IVF conception, or history of FGR in previous pregnancy. Now when we saw the results, we saw that the distribution, the most important high risk criteria were obesity, history of ART, and increased uterine artery Doppler in the done in the second trimester, early second trimester scan. And when we saw the predictive performance of SFLT1 PLGF ratio, we saw that out of total 31 patients who had a SFLT1 PLGF ratio of less than 38, 30 of them did not develop preeclampsia, which gives a very high or good association between the absence of preeclampsia and a low SFLT1 PLGF ratio. The negative predictive value came to be around 96.7% and a positive predictive value of 63.5. The sensitivity was 92.3 and the specificity was 81%. So similar studies have been done in the past and many of them have given the similar results. The first one was evaluation of SFLT1 PLGF ratio done by Helene Kahlon et al. It was published in the PubMed in 2018 and they came out to have a negative predictive value of this ratio of around 100%. Then the STEP study, which was carried out by A. Perols et al., published in 2017, and they also came up with the similar results. The prognosis study, which was one of the major studies done in this, on this subject, which was published in the New England Journal of Medicine in 2016, and they also showed that this ratio of 38 or lower can be used to predict the short-term absence of preeclampsia in women in whom it is suspected clinically. So all these studies favor my diagnosis, favor my results. So to conclude, I would like to say that SFLT1 PLGF ratio of less than 38 is a promising predictor for ruling out the development of preeclampsia, and a value of more than 38 is a strong marker for subsequent development of preeclampsia in the late second trimester. It was a self-funded study, there are no conflict of interest, but the limitations of my study was that it had a small sample size and it was done at a single center. These are my references. Thank you.
This is really absolutely marvelous. Did you try using a cutoff of 85 to improve the positive predictive value of the ratio?
Sir, it was a very small sample size. So most of them had like in this case, had out of 50 patients, 31 of them had a value less than 38.
Right.
But yes, sir, more than 85, I got in around 2 patients, and all of them had a severe FGR later on. At around 34 weeks, I think, they had a severe FGR.
Yeah. And of course, the next stage would be to be able to assess them for what happens closer to the event.
Yes, sir.
Which means that we can really evaluate. And do you have the sera stored of these patients?
Yes, sir.
Do you have the serum stored up of these patients?
So, yes, I mean, not exactly stored up, but then some of them, I have requested in the lab to kind of preserve these serum for these patients,
Yes.
so that we can evaluate further and we can carry on test if required.
That's right, because we know that this serves as a screening test.
Yes, sir.
And the data in the last 1 year that has been presented, and in fact came out just last week, is that methylation studies using an NGS, a sequencing technique, would be diagnostic rather than screening.
Yes, sir.
And we're trying to validate that on Indian patients.
Yes, sir.
And our Society of Fetal Medicine has collaborated with one of the companies to do these free of cost.
Yes, sir.
So if you have a follow-up and we have the serum, then we would be excellently able to follow these up for you.
Yes, sir, sure,
So be
sir.
in touch with me on email and
Yes,
we can
sir,
work
sure,
it out.
sir.
Yeah.
Sure, sir. Thank
Yeah.
you, sir. Thank you.
Thank you for an excellent study and wonderful presentation. I had one question.
Yes,
Your
ma'am.
inclusion criteria had women who had high increased
Yes,
PI. So how many of them were on aspirin already, and did that confound the
Ma'am, most of
reports?
them were on aspirin.
Right.
Most of them were
most
on
of them.
aspirin. Yes,
and
ma'am.
despite that, some people did develop,
Yes, ma'am. Despite that, some people, because we usually start aspirin for all
Earlier.
those patients who
Yeah.
are at high risk of developing preeclampsia.
Yeah.
So most of them were on aspirin already, but still they had a high propensity, or they developed eventually preeclampsia.
So were they on 150 milligram of aspirin? That's the second question.
Yes, ma'am.
Okay.
Yes, ma'am.
Okay, thank
Because most of them were obese. I mean, so most of them were on 150.
Which lab do you send the sample? And in how many days you get the reports?
Yes, ma'am. So there are 3 labs currently. One is Metropolis lab, which sends their reports to Mumbai, and then the cost comes around 6,500 to the patient. And it is done by electrochemiluminescence. Here, I usually send it to Lupin Diagnostics, and they give results in around a week. They give around 4 to 5 days, but it eventually takes up a week. So, and the limiting factor here was they collect samples only 3 days a week.
Correct.
They collect it on Monday, Wednesday and Friday. So then that is how, ma'am, I had to call my patients accordingly.
Sorry, but I just want to know one more question. Is that, did you repeat it again? I mean, because
No,
the
ma'am, I did
predictive
not
values
get.
for a
No,
week.
ma'am, I did not, because of the cost factors.
Yeah, that's
I
right.
did not get a chance, because it comes to be around 6,500. So just asking them to pay that much
Absolutely,
again.
that's fine,
And ma'am, for early onset, my main aim was to detect cases who are at a high risk of developing an early onset preeclampsia. So that, and late onset, we can always give steroids and deliver them accordingly. So early onset are the ones who have a high burden on the society, because then keeping the baby in the NICU and then counseling them, all that becomes important. So thank you.
Very
ma'am.
nice presentation, ma'am. You should be applauded for doing a research work at your own center.
Thank you, ma'am. Thank you.
Being in private practice, we know that it is really commendable to do it.
Thank you, ma'am.
Excellent work. And if you really want to take this ahead, we actually have the labs who are doing this. They will collect samples every single day. All you have
Thank
to
you,
do is to, again, email us, and we will make sure that the sample gets picked up. If you do it as a study, it becomes free for your patients. And
Sure,
for the
sir,
patients
sure.
who can afford it, the price has really come down to 3,400. And we have again...
Right
2
now,
labs,
sir,
yeah.
the only Lupin Diagnostics, they have offered that they'll do the test at around 4,500. But
Right.
then I'm not very sure. I mean, I haven't sent any sample to them.
Right,
So
yeah.
right now, only Metropolis and only one collection center. There's one guy who comes and he takes the sample for 3 days a week. So
Yes,
that is
but
how
it
I'm
can be
doing.
worked out, and
Yes, sir.
the main thing is to actually be aggressive. I mean, we've done this in the middle of Purnia, which, you know, nobody ever expected such fabulous work to come
Thank you,
out from
sir.
there.
Thank you, sir.
And it makes us so proud, and you know, this is why we're calling this the inaugural meeting of the Bihar study group, but by the end of the day, we have so many members that it becomes a regional chapter. So congratulations for being a part of it, and fabulous presentation.
Thank you, sir. Thank you so much. Thank you, sir.
Our next speaker, Dr. Ayushi Varshne.
Congratulate everyone for coming in on time.
Good morning, everyone. I am Dr. Ayushi Varshne from Department of Radio Diagnosis, IGMS Patna. The topic of my poster is Prenatally Detected Open Neural Tube Defects, JRE2 Malformation, a case series. As we all know that the CNS anomaly occurs with a frequency of 1.4 to 1.6 per 1,000 live births and in 3 to 6 of the stillbirth. So we have to take 3 standard transaxial plane, that is transthalamic view, ventricular view and transcerebellar view, which forms the routine scanning view in the brain, and 5 standard planes which assess the spine and the posterior neural arches. The objectives were to evaluate the role of high resolution ultrasonography in open neural tube defects as an absolute screening modality in pregnant patients and their pictorial depiction. We will learn in this poster that there are indirect signs which in the brain which tells about the spinal abnormality at a very early age. The case which we scan at 14 weeks shows the normal lateral ventricles which are filled by the choroid plexus, and there is decreased aqueduct slivers to occipital bone distance, which at RCRL, that was 85, was about to be 5.7, but it was decreased in this case. This case shows the normal aqueduct of slivers to occipit bone distance. Here in this image we can see there is a widening of posterior ossification center in the lumbosacral region. In this figure shows there is increased brainstem to brainstem occipital bone distance, which is normal ratio is less than 1, but in our case it was more than 1. These 2 transvaginal images shows there is an angulation deformity at the lumbar region with a sac at the lumbosacral region which appears to be meningomyelocele, and the 3D rendered image showing the sac in the lower lumbosacral region. The next fetus was an antenatal scan at 18 weeks 5 days, and here we can see the lemon sign, that is the indentation of bilateral frontal bones with ventriculomegaly. The banana sign, which shows there is an effacement of cisterna magna as well as compressed cerebellum. Now here in this image we can see the splaying of the lamina and this is the myelomeningocele sac. The lumbar deformity, this is the lumbar deformity with disorganized neural tissue and the myelomeningocele sac. The next case was an antenatal scan at 30 weeks 3 days, in which the first image shows severe asymmetric ventriculomegaly. The sagittal spine shows low-lying cord herniating through the spinal defect, and here the lumbar vertebrae are numbered, and over this a myelomeningocele sac is seen. The D image shows a right-sided club foot, and the left lying down adrenal is seen as the fetus was having absent left kidney. So if we found a fetus of this, then we have to counsel the mother. But if the condition is isolated, then the etiology is usually multifactorial, genetic and environmental factors such as folic acid deficiency, pregestational diabetes, low maternal blood levels of vitamin B12, maternal intake of warfarin and vitamin A, and prenatal history of spina bifida has to be taken care of. So, in next pregnancy, the preconceptual folic acid and vitamin B12 intake is required. However, if there are more than 2 systems involved, then we have to think about the chromosomal or genetic etiology. So the take-home message is the indirect signs of open neural tube defect in the brain, especially in first trimester, points towards a spinal abnormality. The prognosis is better for lower reasons, the lower lumbar or sacral, closed defects, minimum or no hydrocephalus. But we have to talk to the pediatric neurosurgeon as the prognosis cannot be predicted prenatally and it has to be discussed with them only. Thank you.
This is excellent. It's a very well illustrated series and you worked really hard on this. Very well done.
Thank you.
Thank you so much. Wonderful images and nicely picked up. And I assume most of them ended in termination, is
Yes,
it?
ma'am, all of them.
Yeah, so again, no chance of any genetic workup on them. Was it done in any case, or there was no associated anomalies anywhere, was it?
No, ma'am, no.
Okay.
Very well demonstrated.
Thank you, ma'am.
Good. Nicely presented, especially pointing that neural tube defect can be seen in first trimester or NT scan is really good.
Thank you, ma'am.
Our next speaker is Dr. Bhumika Dhamija.
Good morning, everyone. The topic of my poster is navigating a rare case, collagen 1A1 associated osteogenesis imperfecta from the prenatal diagnosis to the infant outcome. The objective of this poster was to describe the clinical trajectory of osteogenesis imperfecta, which was associated with collagen 1A1 gene, with specific focus on prenatal diagnosis and to correlate the imaging findings with the outcome during the infancy. As we all know, osteogenesis imperfecta is a rare disorder and it is diagnosed in approx 1 in 15,000 to 20,000 pregnancies. It can be inherited in autosomal dominant, autosomal recessive and X-linked recessive manners. Multiple long bone fractures and demineralization is the characteristic of this disorder. With the long bone, when the long bone measurements are less than 5th percentile, the suspicion of skeletal dysplasia should be considered. This is the case of a 20-year-old female who presented to us at 32 weeks of gestation. The ultrasound evaluation showed bowing of humerus, as you can see in the figure A. In figure B, there is a fracture with callus formation in the radius, and in C, there is a fracture with callus formation in the ulna. Figure D shows unusually prominent falx with no deformation of the skull on probe pressure. Figure E shows rib fractures with callus formation. Once we have diagnosed that there is a skeletal dysplasia, we need to assess the lethality of the situation. So for that, the fetal chest and abdominal circumferences were taken, which came out to be 0.83, and in our case, and the femur length was less than 4 standard deviation. And the ratio of the femur length to the abdominal circumference came out to be 0.2. However, the length was less than 3rd centile. The ratio of the femur to the foot length measured 0.78, which was less than 0.9. And as you can see in figure F, there is no evidence of any platyspondyle, and the spine shows normal mineralization. In 3D reformatted image of the face, it showed mild flattening of the nasal bridge. However, there is no evidence of any frontal bossing or micrognathia. On postnatal findings, the baby had a weak cry and it was a normal term birth. The baby had poor tone, blue sclera was present, and as you can see in the figure A, there were fractures in the humerus, radius and ulna with presence of callus formation and limb deformity. The baby had to go for admission in NICU in view of respiratory distress and was started on mechanical ventilation. Chromosome sequence, the exome sequencing was done for this patient, which showed mutation in collagen 1A1 gene, which was consistent with osteogenesis imperfecta. The patient succumbed to death after 22 days of life due to respiratory distress. So to conclude, Obvious fractures in upper limb and lower limbs with hypomineralization of the bone should point to the diagnosis of osteogenesis imperfecta. And 3D ultrasound can aid in the diagnosis of it, especially for the evaluation of face and foot deformities. Thank you.
Excellent, that's fantastic. And could you please tell us how you convinced the patient to get the test done?
Sir, actually, this was a nulliparous patient, and she was planning a further pregnancy also. So, since it's sir, we found that it was going in view of the let's say imperfecta type 2, which can be autosomal dominant and can be expressed in the further baby also.
Right.
So we counseled her, and she was agreeing for it.
Excellent. So we pick on the most delicate point and we drive it home to the patient and we achieve exactly what we need. And you've already answered my second question, that this has a major implication on the type of osteogenesis imperfecta.
So she had a
and
second
therefore
baby
on
also.
the prognosis.
It was normal.
Yes.
Now only she delivered.
Excellent.
Thank you so much. Excellent presentation. So the next question is with the parents tested as well?
Ma'am, actually, the father had, he was also positive. We got them tested also. The father was positive, but he had, due to the variable
Penetrance.
expression of this disease, so he wasn't that symptomatic.
Okay, thank you so much. Thank you.
The next speaker, Dr. Tariq Imran.
Good morning, respected teachers and dear colleagues. I am going to present a poster on prenatal diagnosis of congenital pulmonary airway malformation type 3. Learning objectives are to understand the characteristic USG findings, which are intrathoracic echogenic mass, which may be solid or solid cystic, cardiomediastinal shift, abnormal CPAM volume ratio, can be associated with polyhydramnios or hydrops. The lesion is supplied by pulmonary vessels. Sonological criteria to prognosticate the outcome using CPAM volume ratio. If it is more than 1.6, then there is 80% risk of developing fetal hydrops. If it is less than 1.6 and associated with a dominant cyst, there is risk of acute increase in size of the cyst and developing fetal hydrops. If it is less than 1.6 without associated a dominant cyst, then there is 2.3% risk of developing fetal hydrops. To differentiate CPAM from pulmonary sequestration, which is an abnormal proliferation, bronchial proliferation, and does not communicate with bronchial tree, the lesion is supplied by systemic vessel, mainly by descending aorta, as opposed to CPAM lesion, which is supplied by pulmonary vessel. Congenital diaphragmatic hernia, the defect in diaphragm and visceral herniation can be seen on a coronal diaphragmatic view. CPAM is a rare developmental anomaly affecting the fetal lung, characterized by multicystic masses of segmental lung tissue with abnormal bronchial proliferation. It can be associated with pulmonary sequestration, as in hybrid lesions, polyhydramnios due to esophageal compression, hydrops fetalis due to vascular compression, and can also be associated with various congenital cardiac anomalies. Pathology behind CPAM: failure of normal bronchoalveolar development with hamartomatous proliferation of terminal respiratory units. There are 5 subtypes, type 0 to type 4, based on size of cysts. CPAM is unilateral in 95% of the cases. Coming to my case, T5 scan was done for a 21-week, 5 days fetus. A hyperechoic lesion was seen in left hemithorax, as seen in the first image, causing mass effect on heart and mediastinum. The heart is shifted towards right, as seen in the second image. On color Doppler study, the lesion was supplied by pulmonary vessels, as we can see in the third image. The CPAM volume ratio was 1.16, prompting weekly follow-up to see the early signs of fetal hydrops. Concluding, USG allows for the early detection of CPAM during routine prenatal screening and aids in assessing the risk of complications associated with CPAM. Early diagnosis allows for detailed and informed counseling for expectant parents and multidisciplinary care for optimizing outcomes. Thank you.
Thank you for the wonderful case. Is there any follow-up for this patient, or is it just ongoing pregnancy?
Yes, ma'am. In the 28th gestation week, we found that the growth was already stabilized.
Right. So what do you think is the maximum time when this CPAM grows? When does it stabilize?
Ma'am, till 26 weeks it grows.
Yeah, thank you. So most of them tend to resolve.
Yes, ma'am.
And did the polyamnios resolve as well by then?
Yes, sir.
The polyamnios also resolved by then, or the polyhydramnios was still there when you saw it at 28 weeks?
So there was still polyhydramnios.
Yeah, but it probably go away and they have an excellent prognosis.
Yes.
How do you monitor it? The CVR is more than 1.6?
If it is more than 1.6, then we follow the patient twice a week to see the early signs of hydrops.
And what about the CVR less than 1.6? Till when do you monitor it weekly?
Yes.
Till
26 weeks we ask the patient to follow up.
And after that?
Then after, there is very less chance of developing hydrops.
We still have to look for the development of CVR, especially if there is a dominant cyst, it can enlarge any time. So you have to keep monitoring it.
Yes, ma'am.
Did she reach the term pregnancy term?
We still have to follow. This is recent
she is
case.
still on the follow-up.
Yes, ma'am.
Make sure they have a postnatal CT because they always.
Yes, ma'am. Sure, ma'am.
Excellent, well done. Thank you.
Our next speaker, Dr. V. Ruchika.
Good morning, respected teachers and my colleagues. I am here to present a case on fetal megacystis. Fetal megacystis is defined as increased longitudinal bladder length, which is more than equal to 7 mm in first trimester, more than 30 mm in second trimester, and more than 60 mm in third trimester, as measured in mid-sagittal plane. It is important to detect and diagnose this condition, as fetal urine is the major contributor of amniotic fluid volume in second trimester, and any defects can alter the fluid dynamics and lead to oligohydramnios, renal dysplasia, and pulmonary hypoplasia. Oligohydramnios and pulmonary hypoplasia being the major cause of perinatal mortality. This is a case of a primigravida who came for antenatal scan in which megacystis was detected at the end of first trimester, along with bilateral hydroureteronephrosis and keyhole sign. Liquor was, however, normal. In the above images, we can see a longitudinal bladder diameter of about 22 mm and a keyhole sign, and bilateral hydroureteronephrosis. The couple was advised for invasive chromosomal assessment to rule out any aneuploidies which are associated with this condition. However, they refused. On follow-up scan, in second trimester, the bladder diameter had increased to a diameter of 37 mm, along with oligohydramnios, cystic dysplastic changes of kidneys, as in both kidneys, and bilateral megaureter. As we can see in the images, the first image shows bilaterally echogenic kidneys, which are indicators of renal dysplasia, also bilateral megaureter. The bladder diameter had increased to 37 mm. A very large urinary bladder with bilateral megaureter. The umbilical cord was assessed for any cyst that shows association with urethral atresia. No cyst was, however, noted. The couple terminated the pregnancy. The fetus turned out to be male. Now, the causes of megacystis are divided into obstructive, non-obstructive, and idiopathic transient. As for the diagnosis of the case, there could be two probable causes for megacystis. One obstructive, under which there was high chances of it being lower urinary tract obstruction or PUV, as it was a male fetus with keyhole sign, which although is not a reliable indicator of PUV and occurs in 51.6% of PUV cases and in 34.8% of non-PUV cases, as for example, in vesico-urethral reflux. Therefore, second probable diagnosis could be non-obstructive cause, that is vesico-urethral reflux. Other causes were ruled out as no associated findings were noted in the fetus. The trisomies 13, 18, and 21 associated with megacystis is such that the bladder diameter measuring 7 to 15 mm show 25% risk, and those measuring more than 15 mm show 11.4% risk. However, regardless of the bladder diameter, karyotyping is important in all cases of megacystis. In chromosomally normal fetus, megacystis is usually associated with progressive obstructive uropathy. Many studies have reported that megacystis detected in first trimester with a diameter of 7 to 15 mm may show spontaneous resolution in 90% of cases, whereas those measuring more than 15 mm show poor prognosis as seen in the case presented. The antenatal management of megacystis is mainly aimed at restoring amniotic fluid volume in order to prevent oligohydramnios and pulmonary hypoplasia. Fetuses with no complex megacystis, no umbilical cord cyst, and bladder diameter of more than 15 mm are selected for the therapy. Thank you.
Fantastic. Thank you for the presentation and lovely images as well. I don't have any questions. Very good.
It's so wonderful, and it's nice to see everybody. It's nice to see you following every single rule that needs to be followed in the evaluation of a patient. Keep up this excellent work.
Thank you, sir.
Nicely presented.
Yes, very well demonstrated, very well.
Thank you, ma'am.
Our next speaker, Dr. Kumari Neha.
Good morning, everyone. Myself Neha, junior resident from the Department of Radio Diagnosis from IJMS Patna. Today I am here to present a case of prenatal detection of Down syndrome through ultrasound. The objective is to highlight the importance of soft markers of aneuploidy in the first trimester scan and to evaluate for the fetal cardiac defects in patients with increased NT. The case history is in such a way that a primary gravida 25-year-old lady came to the department for the first time scan at 13 weeks. And she was having normal menstrual cycles and was on treatment for subfertility, and she had conceived by IUI using husband's semen. And there was no risk factors present at that time. So on ultrasound, we found that the NT was raised and it was about 4.4 mm. And we can see also in the image, there is mildly posteriorly placed mandible, so it raised the suspicion of retrognathia, and also the nasal bone was absent. So we did, since the NT was raised, so we did the fetal echocardiography, and in the fetal echocardiography we found there is absence of the crux and common single valve is present. In this video we can also see clearly. The video is not playing, I think. So it was, in the video also, it was showing the absence of the crux with a common single valve. So we did, after that we did the DV, and in DV we found there is mild reversal of the A wave. And in the tricuspid waveform, we found there is regurgitation. There is regurgitation, and the peak systolic velocity at that time was 80 centimeter per second. So with all the findings, we can see in the video that the crux is absent and with a common single valve. So with all the findings, we counsel the patient for undergo for the invasive testing, that is chorionic villus sampling, but the patient was not willing for the same. And she again came for a review ultrasound at 16 weeks. And all the findings were reconfirmed, and we found that the nasal bone is still absent, but the anti resolved to 3 mm only. And we can also see in the tricuspid regurgitation image, there is diffuse subcutaneous edema, which was resolved in 16-week scan. So this time she was willing to undergo. So we did the amniocentesis and sent the sample. And after 3 days, QF-PCR report has come, and it showed 3 copies of the chromosome 21. And so we convinced her to undergo karyotyping to look for what type of karyotyping it is. So we can know the recurrence rate in the next pregnancy. So in karyotyping, we can see there is complete copy of additional chromosome 21 is present, which in report summary we can see 47 plus 21, which showed that there is pure type of trisomy in the karyotype. So why it is necessary to know the recurrence rate in the next pregnancy. And in the pure type, the recurrence rate is less than 1%. And if it is translocated Robertsonian type, and if the father is the carrier, then the chance is 2 to 3% only. And if mother is the carrier, the chance is only 10%. So I would like to conclude my points, these 3 points, that the presence of soft markers in the first trimester pregnancy is very important to look for the chromosomal etiology. And if anti is increased, we should always look for the underlying cardiac defects. And if transabdominally we are not able to see, then we should always go for transvaginal fetal echocardiography. And third, we should always encourage the patient to go for genetic evaluation and the karyotyping to know the recurrence rate in the next pregnancy. Thank you, ma'am.
Thank you for wonderfully demonstrating how to evaluate these cases. That's beautifully shown. Thank you very much. And the important message, I think, is don't do a first trimester screening when you see such findings. Go directly for invasing. Yes, thank you very much. Very nicely.
Thank you, ma'am. Was this a natural conception?
Yes, ma'am. She was under treatment, but she was only the she was not artificially conceived, but she was under treatment.
Okay.
Yes, ma'am.
Okay.
Yes, ma'am. Yes, ma'am.
Okay. And what are the other causes of increased NT?
Ma'am, other causes could be other anomaly defects like adverse syndrome or Patau syndrome, but in follow-up scan, most of the time the anti resolves. So we should always go for the karyotyping or the genetic evaluation to rule out these effects.
Yes. Yes, very good.
Thank you.
Well done.
What are the major structural abnormality? If you get in second trimester scan, you directly go for karyotyping for aneuploidy.
Yes, ma'am. Since the patient was of first trimester scan, so we did not sort.
You had the 16th.
Yes, ma'am. Yes, ma'am. That time we did not other.
In general,
features.
I'm asking what are the major structural abnormality which directly points towards aneuploidy, and if you
short,
get
long bones, we can see, or echogenic bowel, echogenic focus.
Those are the soft markers here. It is atrasias, the duodenal atrasias,
yes,
or the esophageal atrasia, or if you get something like that, then you should go for it.
Mild ventriculomegaly and pilectasis.
Especially in your case, like AVSD was there,
yes,
especially if it is a balanced AVSD, we directly go for karyotyping. We don't go for any other screening methods.
Yes, ma'am. Yeah. Thank you, ma'am.
Very nicely present.
So our final speaker for this free paper session, Dr. Dipali Prasad.
Good morning to chairperson and all the audience present here. Today, my topic for presentation is prediction of preeclampsia at 11 to 14 weeks of pregnancy using maternal characteristic, mean arterial pressure, uterine artery Doppler,
a prospective study in Tertiary Care Center of Bihar. So coming to introduction, preeclampsia is a complication that affect between 2 to 8% of pregnancy as one of the world leading cause of perinatal morbidity and mortality. Preeclampsia is a syndrome generally defined as a combination of the onset of hypertension after 20 weeks of gestation and proteinuria, and it causes immediate maternal adverse effect including impairment of hepatorenal and coagulation system. If left untreated or in severe form, maternal pulmonary edema, eclampsia, brain injury and death can occur. And evidence suggests that administration of low-dose aspirin before 16 weeks of gestation significantly reduce the rate of preterm preeclampsia. Therefore, it is important to identify pregnant women at a risk of developing preeclampsia during first trimester of pregnancy and thus allow timely therapeutic intervention. So aim of the study is to predict preeclampsia at 11 to 14 weeks of pregnancy. And our objective is to predict preeclampsia using FMF calculator using maternal characteristic, mean arterial pressure and uterine artery PI, and to determine the effectiveness of first trimester screening for preeclampsia. And it is a prospective cohort study of 1 year duration, and all antenatal women attending IJMS OPD at 11 to 14 weeks of gestation having singleton pregnancy and willing to follow up. And exclusion criteria include multiple pregnancy, congenital anomalies in the fetus, and pregnancy with essential hypertension, and one on antihypertensive medication. So in the method, the risk assessment 11 to 14 weeks of gestation week that incorporate clinical demographic details, mean arterial pressure, uterine artery pulsatile index, and the mean arterial pressure was measured simultaneously in both arms using calibrated mercury sphygmomanometer with the patient in a seated position and repeated after 1 minute interval. The risk for each woman was estimated using an online calculator provided by Fetal Medicine Foundation, and using the study ANS antenatal care population should be categorized as low risk, high risk, and high risk population was vigilantly under surveillance and monitored, and while the low risk were followed during the regular antenatal visits. So the pregnant woman identified as a high risk based on cutoff of 1 in 150 were recommended low dose aspirin, that is 75 mg once daily at bedtime up to 36 weeks, and development of preeclampsia after 20 weeks of gestation until delivery was assessed from medical record. So in the result section, we screened 133 patients at 11 to 14 weeks. Among these, 42 were developed high risk as the FMF calculator. Of these, 23 patient developed features of PIH and related complications like preeclampsia, eclampsia, IUGR, oligohydramnios, while 19 patients developed no such complication. Among these, 91 patients who were not considered as a low risk, and 15 developed the features of PIH, and 76 of them have no such complications. The screening turned out to be 60.5% sensitive, 80% specific, 24% positive predictive value, and 90% negative predictive value. So in discussion, so in this recent time, the prediction of complication of the late pregnancy from as early as first trimester has been possible. Our result has supported this idea of predicting preeclampsia and its complication at early at 11 to 14 weeks gestation. The present study show 42 patients were of high risk and 91 patients of low risk as per the FMF calculator, and Sheila et al. Presented same as this. And according to Samrakshan protocol for the identification of the pregnant woman at a high risk of preeclampsia, shows sensitivity of 64%, specific 90%, 24% positive predictive, 91%, 98.1% as negative predictive value, as same as it is almost comparable to our present study, as our present study turned out to be 60.5% sensitive, 80% specific, 24% positive predictive, and 90% negative predictive value. So coming to the conclusion, this screening method was simple, uncomplicated, easy to perform for the attending doctor, accessible, feasible, and affordable to the patient. In the preeclampsia, maternal characteristics like BMI, mean arterial pressure plays an important role. An FMF algorithm has been effective in predicting preeclampsia and has proved to be an important step in prevention of preeclampsia and its complication. It became very important to develop and concise an algorithm like FMF calculator, and this result support the notion of prevention therapy in patients who are at high risk. Thank you.
You've done this very nicely, but we have a sensitivity of 60%.
Yes.
we know that for any screening test, we need at least 65 and preferably 75%. What do you think was missing from this that made us fall so low? Because at this rate, if we come down to 50%, we would be justified in giving aspirin to everybody, which would be a disaster. So something has gone seriously wrong here, where we've not achieved 75%. And literature is now claiming to be between 90 and 100%. So we haven't used biochemistry
So very
as
challenging
a
in
parameter.
our studies. Most of the patients, they don't come at 11 to 14 weeks. Most of the patients,
Yes.
they either come earlier or after that. So it is
Yes.
one of the very challenging. And in our government setup, we don't have the limitation of this study. We don't include this biomarker.
So are
in
you
our
doing
study.
anything to be able to include it? Have you put in an email to the department saying that this is a great killer in our area and we definitely need to do a PLGF, at least if not PLGF plus PAPE, because PLGF is not expensive at all.
Yeah. So even doing this, I think I want to say that even with this doing, we are able to detect around 80% of our patient with this maternal characteristic mean arterial pressure. With this simple, not doing PLGF and all these, we are
No, we
able
have a
to catch
60%
and
sensitivity, no?
sensitivity is more, if sensitivity is to be increased, that means.
So for a screening test, that's what we're looking for, and we're
Yeah.
looking for a negative predictive value.
Yeah.
But if our sensitivity is only this much, it's not acceptable as a screening test.
Okay, sir.
So we
I have
should
to
not
increase it.
use something which is partial
Yes.
when something better is available, especially when the disease is so devastating and has such a marvelous way of being prevented.
Yes.
All we have to do is that the patient should be compliant, make sure she takes her aspirin, and
Yeah.
she will be fine. On the other hand, these are the patients who will get to spend 4 times the cost of PLGF for a single day in the NICU. So if 4 times the amount of PLGF is being spent for one single day of neonatal care, then this method is not justified.
Okay, sir.
Yeah, so we must push for the right method in the right way, because the government will never listen. That
Yeah.
is what politics is all
Yes,
about.
yes, sir.
But we are science and we have to push things correctly.
Okay, sir.
But I'm so glad you started somewhere and achieving something somewhere. Next year, please
Yeah.
make sure it's included, and we'll make you part of a national study. If you want to have a proper study,
Yes.
including PLGF, then again, email at us as Society of Fetal Medicine, and we'll arrange the PLGF free of cost for you, for all your patients, even if you have 10 patients a day in your government organization. It is possible. Yeah.
Thank you, sir. Thank you, sir. Thank you, sir.
Thank you for that wonderful study. The other thing I noted was you put all of them on 75 rather than 150. Do you
Yes,
think that sort
we
of decreased the sensitivity
We
of the...
are using 75. We are giving 75.
Yeah, but the recommendation is especially, of course, with PLGF, but it would help if it has increased to 150, isn't it?
Okay.
Thank you.
Okay. Thank you, sir.
Thank you. It's been a truly marvelous session. I think there is no dearth of hard work in our country. There's no dearth of excellent work in our country. We are still running on time, not bad
Yes,
at
sir,
all.
we are running on time.
And well done, and let's go ahead with the rest of the session. My congratulations to the Bihar Study Group for getting this off with such a beautiful bang. Well done.
Thank you, sir. Thank you, judges. Thank you, the audience, for the patient listening. Now, without further delay, we will move towards our next session. The winners of the paper presentation will be announced at the end of the academic session, so please wait